Good morning, everybody. I'm Dr. Neelam Pawar, pediatric ophthalmologist from Aravind Eye Hospital, India, and very warm welcome to CyberSight live webinar. I will be presenting on myopia in treated retinopathy of prematurity, and I'm pediatric ophthalmologist at Aravind Eye Hospital, India, and currently a research scholar at Kellogg Eye Center, University of Michigan. I'm having no financial interest in this presentation. ROP is a global public health problem, and because of increased neonatal care and improved NICU setting, we are seeing an increasing prevalence of ROP in both developing and developed countries. And geographic differences do occur in the epidemiology of ROP because of disparities in neonatal care. And recently, there has been surge in publications and researches on ROP. This talk is more as perspective of pediatric ophthalmologist. This article in Journal of Pediatric Ophthalmology and Strabismus reported that retinopathy of prematurity is second most written about and cited topics of top 100 articles in pediatric ophthalmology, followed by myopia. So this lecture will focus and explore on dynamics of myopia development in both treated and untreated cases of ROP. It will highlight recent findings on the myopia development and evaluation of various factors which are associated with preterm babies who are not only treated with anti-VEGF or laser photocoagulation, but we'll also see what happens in untreated patients. And we will have discussion on latest research findings, clinical insight, and potential strategies in context of myopia related to ROP. So this is the global map which shows the burden of visual impairment due to retinopathy of prematurity. And if we see Sub-Saharan Africa and North Africa and Middle East have higher percentage of visual impairment and blindness due to ROP, while high-income countries have least prevalence of visual impairment due to ROP. The most important risk factor for developing ROP is prematurity and low birth weight. However, there are more than 50 separate risk factors which have been identified and associated with ROP, and if preventive factors are taken care, the prevalence of ROP and severity of ROP can be reduced. The vascularization of the retina begins approximately 15 to 16 weeks at optic disc, and later on it goes into peripheral retina. It is completed by 32 weeks at nasal retina and by 40 weeks at temporal retina. So in case of preterm birth, there is initial relative hyperoxia, and later on, because of the repeated fluctuations of supplemental oxygen, there is dysregulated signaling pathway which leads to phase 1 of ROP, where there is compromised physiologic vascularity, and later on phase 2 where there is vasoproliferation and ultimately a fibrovascular phase. So there are various studies on screening of ROP which are based on different algorithms in different countries. Until now, GROP shows the maximum sensitivity and specificity for detection of ROP. There are various oxygenation target studies to set a oxygenation target for ROP babies, and there are various treatment studies which are different landmark studies such as cryo-ROP, ET-ROP, BEAT-ROP, and RAIN-BEAT trial. And we will focus mainly on these studies and myopia related to these studies. So Dr. William Good, in one of his commentary article in Ophthalmology, re-emphasized the fact that genetic factors could play an important role in prevention of ROP, and it is the post-conceptional and gestational timing which is more important than the postnatal. So he again re-emphasized that people should undergo and read this early report of incidence and early course of retinopathy of prematurity, which was a remarkable trial, that is the cryotherapy study for ROP. The world has seen 3 epidemics of ROP. The first epidemic was seen in 1940 in US and Western Europe because of unmonitored 100% supplemental oxygen, and later on second epidemic was seen in 1980s because of greater survival of increasingly preterm infants. And in late 80s and early 90s, third epidemic was seen in Eastern Europe and Latin America, and then in early 2000 in East and South Asia, and in 2020 it is seen in Sub-Saharan Africa because of the expansion of intensive neonatal care, which is often because of poor quality services and low coverage of ROP. There's a recent surge in cases of ROP in Africa, and it raises the alarm whether we are stepping into fourth epidemic of ROP. So Gilbert et al. In their remarkable study, they found that countries with high levels of development have low birth weight and gestational age criteria compared to low and moderate levels of development in various countries. And if you see this box plot, the median birth weight and median gestational age is quite less in high-income countries compared to low and middle-income countries, and even variations occur in different Asian countries also. So this is the comprehensive list of ROP screening guidelines across the world. And if we look in this table, countries like Colombia, Costa Rica, Cuba, India, Mexico, Philippines, and Nicaragua, they are having higher birth weight criteria and higher gestational age criteria. The current guidelines in US is to screen babies with a birth weight of less than 1500 gram and a gestational age of less than or equal to 30 weeks, as well as to screen those infants who are having unstable clinical course. While in UK criteria, there is no additional criteria of screening infants with unstable clinical course. So next question comes whether we should screen infants with unstable clinical course. So most of the time we see cases from neonatologists who are having astronomy courses. They are referred to us for screening of ROP. So this study done in Colorado with a very long term from 2006 to 2021 on unstable clinical course, and authors reported that only 6.9% of the baby referred with unstable clinical course developed type 1 ROP, 6.2% developed type 2, while none of the baby had treatment requiring ROP. But still it is worth to screen all the babies with unstable clinical course, because if we can save even one eye with ROP, it is worth to screen all the babies with unstable clinical course. So in 2005, the earlier classification of ROP underwent modification, including plus disease, severity of diseases into stages, and based on zones and clock hours, and inclusion of aggressive posterior ROP. In 2021, the ICROP 3 edition came, which changed the lexicon because of the increasing use of anti-VEGF in the treatment of ROP. So there is a description of reactivation, and one has to see that whether there is a physiologic vascularization after anti-VEGF treatment or whether there is any other pathologic extraretinal neovascularization going on. Reactivation after anti-VEGF includes vascular dilatation, tortuosity, and extraretinal neovascularization. Clarification of regression with reduced dilatation of veins and less tortuosity of arterioles and veins. There's definition of persistent avascular retina or PAR, and there is addition of a posterior zone 2 which is just outside the zone 1. There is new subclassification for stage 5. So along with 5A and B, we are having additional 5C which includes the anterior segment manifestation also, and a broader definition of plus disease and long-term sequelae like glaucoma, strabismus and retinal detachment and various refractive errors. So this is the stage 1 ROP. We can see there is a very fine demarcation line. In stage 2 there is a ridge formation. This is stage 3 with extraretinal fibrovascular proliferation, and this is stage 4 with retinal detachment not involving fovea, and this is 4B where fovea is involved. And this picture is of anterior ROP, the stage 5A where there is open funnel RD, and stage 5B which is closed funnel RD, and stage 5C that along with retinal detachment there's shallowing of the anterior chamber and involvement of anterior segment. So I'm very grateful to Dr. Paraksha for sharing this picture, and Dr. Paraksha was one of the eminent pediatric retina specialists who was involved in ICROP3 classification. So these are again more prominent pictures of stage 1, stage 2, stage 3 and stage 4, and this picture is of stage 4 which is suggestive of pars plana vitrectomy, and thanks to Dr. Syed for sharing this. So it is very important to have a good and collaborative relationship with pediatric retina people and retina specialists, because pediatric ophthalmologists usually follow these cases for long term. So what is myopia of prematurity? It is a form of refractive error related to alterations in the development of anterior segment that occurs in individuals born prematurely. So quite often this term is underestimated, though it is different from pathologic or school age myopia, but ICD classification doesn't have a code for this, so unfortunately we have to always report or code it as simple or high myopia, and unfortunately there is even no mesh terms to search in databases like PubMed or other scholarly systems. So myopia of prematurity can be broadly divided, this is just for understanding, it can be divided as myopia of prematurity where only prematurity is responsible, then myopia of prematurity without treatment, or in cases where there is spontaneously regressed, that is ROP without treatment, then myopia of ROP which result because of sequelae of ROP with treatment, and myopia of adult retinopathy which is known as adult ROP. So long back, Fielder and Quinn published this paper in British Journal of Ophthalmology about myopia of prematurity, nature, nurture or disease. And they stated that myopia is probably the normal refractive state in infants before full term, with the eye becoming more hypertropic in early infancy. And on comparing these eyes with full-term baby, this myopia are of shorter axis length, flatter anterior chamber and more spherical lens. So there are several theories postulated with myopia of prematurity, though none of them is 100% conclusive, but still these theories are postulated to be responsible for myopia of prematurity. So first is the arrest theory, which states that ROP and prematurity lead to blocked development of the anterior segment of eye, which affect the process of orthokeratology and refractive status. And retinal dysfunction theory states that dysfunctional retina alters the eye growth signals. The bone deficiency theory says that MOP could be attributed to postnatal bone mineral deficiency, and temperature theory states that preterm neonates experience usually hypothermia, and they experience a temperature deficit at a time when the corneal growth is especially active. And there is a light visual deprivation theory which states that light exposure in early phases could act as a myopiogenic factor. So RP-induced myopia cannot be fully explained by increased axial length. There is always a non-linear refractive development associated with RP, and prevalence of myopia rises as stage 3 is achieved, and so the prevalence of anisometropia and astigmatism. So, to summarize, 3 types of myopia are associated with premature birth. First is physiological and temporary myopia, which is nature, and second is myopia without ROP, MOP or nurture, and third is myopia induced by ROP, that is disease. So this is the white paper published by International Myopia Institute, and they focused in this article on investigation and management of high myopia in infant and young children, that biometric evaluation including axial length and corneal curvature is very important to distinguish axial myopia from refractive myopia, because refractive myopia are associated with abnormal development of anterior segment. This is the famous curve by Gordon, and if we see, the most of the axial length increases in 0 to 2 years in normal children, while lens power in diopter decreases sharply in 0 to 2 month age. In another longitudinal study of biometric and refractive changes in full-term infant during the first year of life, the regression analysis showed that axial length change was curvilinear, the anterior chamber depth was linear, and while there was no change in lens thickness in children in first year of life. So Gordon et al. In their very small subset of patients with retinopathy of prematurity found in 1986, they reported that children with retinopathy of prematurity have higher lens dioptric value, which was found to be statistically significant compared to full-term babies. So the longitudinal studies of the development of myopia of prematurity indicate that degree of myopia, it is not static from birth, but it develops over from time, and most rapid changes occur during the first year of life. Quinn et al. In their study reported that distribution of refractive error changed between 3 months and 1 year, with very little change after 1 year, while other studies report that myopia continues to increase until 3 years of age and even beyond that. So what about refractive data in untreated ROP? So as we know, ROP is a complex and is having multifactorial phenomena. So it is influenced by the severity, location, and duration of acute ROP. So even in untreated ROP cases, we can see a significant trend of sphere towards myopia. We can see increased magnitude of astigmatism alteration, and there can be increased incidence of anisometropia. So several authors showed that there's a significant trend towards myopia, which increases with ROP severity at initial 6 months of follow-up. So what are the outcomes of untreated retinopathy of prematurity? So in this recent paper published in Journal of APOS, the authors reported outcomes for non-treatment requiring infants evaluated for ROP, and they reported that out of 304 patients, most of them had hyperopia and astigmatism, followed by myopia, and then strabismus and other manifestations. An author again stressed the fact that all the children, even who are with non-treatment requiring infants with ROP, they should be checked by ophthalmologist at 4 to 6 months after discharge from their hospital. And these are even the guidelines given by American Association of Pediatric Ophthalmology and Strabismus. So what is the epidemiology of MOP? The risk of myopia is higher with treatment of posterior ROP with cryotherapy or laser. And in cryo-ROP trial, there was a natural history population group. In that group, the overall prevalence of myopia was 21% among all subjects at 1 year, while subgroup with severe ROP had myopia prevalence of 80%. And overall prevalence of high myopia in untreated group was 3.9% at 1 year, but it was 43% among those with severe ROP. Thus, each 100 gram decrease in birth weight correlated with 10% increase in the prevalence of myopia. The ETROP study, which was the result which was published in 2001, which enrolled participants with pre-threshold ROP, and the prevalence of myopia and high myopia was 65% and 35% respectively. And about 70% of high-risk pre-threshold ROP eyes which were treated with laser were myopic by the age of 4 to 6 years. The BEAT study, which was bevacizumab eliminates the angiogenic threat of retinopathy of prematurity. The study compared the effect of bevacizumab over laser therapy for zone 1 disease in infant with stage 3+ ROP. And this study found that children with zone 1 ROP, the mean spherical equivalent was -1.5 with a standard deviation of 3.2 diopters in the intravitreal bevacizumab group, while it was quite high, -8.44 with a standard deviation of 7.57 diopter in the laser group. So the question arises, why the myopia is less with Avastin or bevacizumab? The intravitreal bevacizumab allows for minimal disruption of the local growth factor and signaling pathways which are necessary for the development of anterior segment, and it stays for just for few weeks in the body. While in cases of laser, there is a larger confluent area which is destroyed by laser, and therefore it disrupts more signaling pathway and alters the anterior segment and leads to more myopia. The RAINBOW trial, which is ranibizumab compared with laser therapy for the treatment of infants born prematurely, the study used ranibizumab 0.2 mg and 0.1 mg, which is cleared more rapidly from the blood and compared to laser treatment. And even this study compared the alternative ranibizumab dosage for safety and efficacy, which is known as CARE ROP study. So what this study found? So this study found that at 24 weeks post-treatment, the success was 80% in infants with 0.2 mg ranibizumab and 75% with 0.1 mg ranibizumab and 66.2% following laser treatment. And at 2 years, there was no new structural abnormalities with the 0.2 milligram dosage, and it was superior to laser therapy in terms of myopia, and it causes less spherical equivalent of myopia. So this Cochrane database of systematic review included 5 trials, RCT trials, which compared intravitreal bevacizumab and ranibizumab with laser therapy, and even one trial compared pegatinib with laser therapy. And this Cochrane systematic review pointed the fact that the monotherapy with Avastin and ranibizumab should be taken with cautious, though these causes less refractive error, but still the chances of reactivation and retinal detachment are high with monotherapy alone. So these are the various anti-VEGF used for the treatment of ROP, and Avastin or bevacizumab is more commonly used worldwide for treatment of ROP, and recently there are various trials going on with aflibercept on ROP management. So what about these anti-VEGF? We still don't know the long-term safety effect of anti-VEGF in infant. There's no correct dose established till date, and long-term outcomes like systemic effect and effect on neurodevelopment with this anti-VEGF treatment is not clearly understood. There is no consensus regarding the frequency of exam, the length of follow-up after treatment, when to discharge the patient, and whether to treat or not to treat the persistent avascular retina, whether to add insurance laser or not. There is always dilemma. So the long-term follow-up studies, including the 5-year extension of Rainbow, as well as Butterfly and Firefly, which is using aflibercept versus laser for ROP, will give us more conclusive result in future. What is the pathophysiology of myopia and high myopia associated with the ROP? So till now we have seen that myopia of prematurity, whether it is associated with the ROP or not, the myopia result due to abnormal development of anterior segment. There is increased lens thickness and power with increasing myopia in ROP eyes. These patients have increased corneal curvature and steepness, and axial length compared to axial myopia. Axial length is shorter, and if you see the position of lens center, there's a more forward position of the lens center, and 50% there's 50% higher in ROP eyes, which contribute to the development of high myopia with shallow anterior chamber. So here is the poll question 4. Do you perform biometry in ROP patient? Yes, no, or sometimes. So 41% of you do not perform biometry in ROP patient, and some of you do sometimes, and 33% of you are saying that they perform biometry in ROP patient. So it is very important to do biometry in ROP patient, because then only we can rule out and differentiate it from axial myopia. So how the treatment modalities may affect structural changes in ROP eyes. So Garcia et al. In their study comparing full-term eyes and ROP treated eyes, they found that refraction equivalent were almost similar. There was no significant differences in the refraction spherical equivalent, but ROP eyes who were treated with cryo or laser had increasing myopia, which was associated with lens thickness and lens power, with lesser contribution from corneal steepness, axial length, and more forward position of the lens center. And they found that ROP eyes had lens thickness by anterior chamber depth ratio almost 50% higher than full-term babies, while Coe et al. Found no differences in axial length between the laser-treated eyes compared to matched full-term eyes or regressed ROP in a follow-up of limited duration. But most of the studies report that axial length in laser-treated eyes or in ROP eyes with the spontaneously regressed ROP, they have shorter axial length compared to matched full-term eyes. So this is a very interesting study which did biometric evaluations of variations in high myopia associated with different underlying ocular and genetic condition, and authors found that patients with treated ROP, they have significantly higher lens thickness and higher K values and lesser anterior chamber depth and lesser axial length compared to the other groups with high myopia. And if we see on comparing with the isolated high myopic group, ROP patients have axial length in the range of 25.3 with a standard deviation of 1.9 millimeter, which is quite less than high myopic eyes, and with the steepness of cornea increased with 45.7 with a standard deviation of 1.9 diopter. Anterior chamber depth was shallow, it was in range of 3 with a standard deviation of 0.5 millimeter, and lens thickness was pretty high, which was in range of 4.6 with a standard deviation of 0.6 millimeter. Thus, the author stated that ROP group had significantly shorter axial length, shallow anterior chambers, and thicker lenses compared with isolated high myopic group, and they concluded that retinopathy of prematurity associated high myopia is primarily lenticular. So this study is the longest longitudinal study which is ever been reported in literature, and this study showed that higher prevalence of myopia and astigmatism was observed in laser-treated threshold ROP eyes on comparison with aged match control eyes, and they focus the important point that myopia and astigmatism in laser-treated ROP eyes typically progress through adolescence after school age. So this paper again tells us that it is not only the school age which requires follow-up for this ROP patient, but even at adolescent also these patients require follow-up. What is pattern in lasered ROP? So longitudinal spherical equivalent in the severe ROP group. In one study, they were best fit with the bilinear model, and before 1.3-year old, the rate of myopic shift was minus 4.7 diopters per year, and after 1.3 year, the rate slowed to minus 0.15 diopter per year, while longitudinal spherical equivalent in mild ROP or no ROP group had a best fit linear model with a rate of minus 0.004 diopter per year. So whether the development of myopia is because of prematurity or laser photocoagulation. So Yenis et al. In their study, they found that in a multivariable linear regression analysis, they reported that the stage of ROP, that is stage 3, and number of laser spots count applied in laser photocoagulation were significantly correlated with the degree of myopia. So whether laser spot count, laser type, area affects the severity of refractive error. So higher is the number of laser spot, more is the myopia. Larger the area of avascular retina ablated, there is greater risk of myopia. Whether the laser is done with diode laser or argon laser, it doesn't matter. And if you see the disease stage, infants with advanced ROP, they are more likely to develop myopia after laser photocoagulation. And what about myopia progression? The stage and zone of ROP have significant effect on myopia progression. More severe the disease, faster is the myopic progression. Anterior-posterior location of the active ROP also correlates with the myopia as well as the extent of final vascularization. And the risk of myopia is higher after spontaneous regression of posterior ROP, that is zone 2, compared to anterior ROP zone 3. And in Asian countries where aggressive posterior ROP is found in higher weight and higher gestational age babies, it has a particularly strong risk factor for the development of high myopia. So does the number of spot is related to amount of myopia? So Galanet et al. In BEAT study, they reported that for every 100 increase in number of laser spot applied, the degree of myopia increased by minus 0.14 diopter. Inu et al. Reported that degree of myopia increased by minus 0.26 diopter for every increase of 100 in number of laser spot, and Yanis et al. Reported that with every 100 increase in number of spot, the myopia increased by minus 0.25 diopter. So myopia in children born prematurely without ROP, that is myopia of prematurity, is negatively correlated with birth weight and gestational age. It tends to be of low magnitude and it lessens with age. While in myopia of spontaneously regressed ROP, it is negatively correlated with birth weight and gestational age, but also with the ROP severity, and myopia usually plateaus at age of 2.5 years. It is of higher magnitude and doesn't decrease with age. So here we will see a couple of examples. So in this patient is in longest follow-up with us, and right now she is 20 years old, and if you see she's having in both eyes minus 12 diopter of sphere and minus 2 cylinder at 180 degree. And if you see her IOL master biometry, the exit length is 25.87 in right eye and 25.84 in left eye, which is quite less. If we see in Indian eyes, the myopia of minus 12 should correspond to exit length of 27 to 28 millimeter. And anterior chamber depth is also very shallow compared to high myopia. It is 2.57 in right eye and 2.83 in left eye. This is another example of 8-year girl and who had laser photocoagulation at 1 month, and if we see she is having in right eye minus 7.5 sphere and cylinder of minus 4.5 at 10 degree, and in left eye she is having just minus 0.5 sphere and high cylinder of minus 3 at 165. And if we see the biometry, right eye is having exit length of 24.09. Again, it doesn't correspond to a myopia of 7.5. She's having high astigmatism, and in left eye if we see exit length is again quite less, which doesn't correspond to the spherical equivalent. It is 21.59. And the anterior chamber depth is pretty okay, and lens thickness is slightly high. It is 3.96 in left eye and 3.86 in right eye. This patient is of post-Avastin, and at 5 years, if we see, he had a very minimal astigmatism of just 0.5 diopter cylinder at 180 degree, and if we see his exit length in right eye, it is 22.28, and in left eye, it is 22.86. The anterior chamber is shallow in left eye, and he is having pretty high lens thickness, that is 4.29 mm in left eye. So what about patients who undergo surgery? So some studies have shown that patients with the 3-port lens parent vitrectomy develop less myopia than fellow eyes treated with the laser alone, while some studies shows that they have high myopia. And one study showed that at 2 years of age, eyes treated with the Avastin had a mean refraction of minus 0.98 diopter as compared to minus 14.38 diopter in eyes treated with lens sparing vitrectomy, but exit length were not significantly different. So with different anti-VEGF doses, the refractive profile changes. And if we see in literature, there are various papers which show about the spherical equivalent and myopia development with the various anti-VEGF, but most of the studies shows that anti-VEGF causes less myopia than laser. So this recent paper studied and reported 2-year outcomes of ocular and developmental outcomes for infants who received the decreasing dose of Avastin. And authors reported that at end of 2 years, there was no statistically significant differences in the neurodevelopmental status, and even there was no significant differences in the myopia development. So this is another study which compared IVR and IVB, and it showed that IVB is associated with the shallower anterior chamber and higher prevalence compared to IVR, and the reason postulated behind is that ranibizumab even stays for less time, and the prolonged suppression by bevacizumab can have greater impact on the development of anterior chamber. Here's the poll question 5. Do you see differences in spherical equivalent in laser-treated ROP and post-anti-VEGF? Always, yes, sometimes, never. So 65% of you opine that yes, sometimes they are able to see the difference, and 14% of you are stating that they never see any differences. The Chen et al. Showed that prevalence of myopia was quite high in laser group compared to IVP group, and the rate of spherical equivalent change was minus 5 diopter per year in laser group, but it was quite less, 3.5 diopter in IVP group after 1 year of age. So spherical equivalent in most of the studies shows that it is higher in laser. So Siemens et al. In their longitudinal study showed that 100% of patients, they develop myopia in zone 1 in laser treated group, and while 88% develop high myopia in laser group. And on comparison with various landmark studies done in comparing IVB and laser, they reported that prevalence of myopia was more in laser treated group compared with IVP group, and zone 1 had higher prevalence of myopia in laser treated group. So our group published a study on refractive profile of children treated with IVB for ROP, and we found that among 134 eyes with 67 study subject, the major refractive error was myopia, which was seen in 93 eyes with a spherical equivalent range of minus 2.89 with a standard deviation of 3.21 diopter. So these are various studies, and this table shows various retrospective and prospective study comparing laser and IVP, and most of the studies, if you see, the spherical equivalent in laser group is quite high than IVP. So biometry in these eye can be done by conventional or optical biometry, and optical biometry is the preferred one. Now what about treatment for ROP myopia? We have to always give optical correction for these children, and these are the guidelines by APOS for the refractive correction in infants and young children, but sometimes we have to give glasses in this ROP patient even if they are having less myopia than this, because ROP patient and mostly those who are treated, they never emmetropize. So what about myopia progression treatment in myopia of prematurity? There is little justification for routine use of currently available optical and pharmacological treatments. Still, atropine treatment and various myopia control glasses is questionable, and IMI white paper stresses the fact that if excessive axial growth is observed along with prematurity, active myopia management would be reasonable approach, but because all the major interventional trials have excluded ROP group, all the major trials like ATOM 1, 2 and other trials which have used myopia control glasses, they have not included ROP group. So parents should be informed of lack of evidence of efficacy in this situation. So retinopathy of prematurity world has seen changes from oxygen management to molecular manipulation of decreasing the dose, same time decreasing the effective management and decreasing the myopia. So there's a long way to go. We have to balance and reducing the dose. Same time, we have to see the neurodevelopmental effect of various agents. We have to always see for cecally, and we have to always aim for lesser myopia. So the important points are that in ROP babies and infant, it is important to monitor the refractive status and eye health of children regularly and provide them appropriate optical correction, and they need a long-term follow-up. And because it is a multi-complex disease and there is variability of dosing and changing different anti-VEGF and laser treatment, so close monitoring and long-term follow-up is required for these children, and biometry is an essential armamentarium in management of ROP patient. So thus, to conclude, these patients are small subset of your pediatric patient, and these children have undergone already a stormy course in their early life, so they need a long-term follow-up, and the follow-up is simple, but one needs a slight meticulous approach, and long-term follow-up is required to see any occurrence of glaucoma, myopia, retinal detachment and strabismus. And field of ROP is keep on evaluating, and right now with advances in telemedicine and artificial intelligence, so one has to update himself or herself regularly. So thank you very much for joining me, and if any questions, I am happy to answer. Yeah, so there's one question in panel: how to treat amblyopia in high ROP myopia? So the management is same as that in the normal amblyop patient, and we have to do routine patching only. This one question: whether optometrist can examine ROP. These ROP patients are very precious baby, and as I already mentioned that it takes a lot of effort by neonatologist and pediatrician and lot of support from parents to bring patient for screening, and already they have such a stormy and bad course. So I will not advocate that any optometrist should examine. Even a general or comprehensive ophthalmologist should also not, they can examine, but I don't think so. They should, optometrists should examine ROP. This field should be limited to pediatric ophthalmologist, pediatric retina, and retina specialist. It's another question. There may be hypermetropia in ROP patient. Yeah, there can be hypermetropia in few series. Even in our publication, we had 15 children with hypermetropia. So you can get hypermetropia in ROP patients. It's a question. If you have an axial progression in ROP baby 21 to 22 but doesn't explain the degree of myopia, you still educate atropine. The role of atropine is really controversial, and still I don't prefer to give atropine in my ROP patient. Rather, most of the time I keep on stopping atropine, which is usually given to patients by some other general ophthalmologist, because these children, they don't emetropize. So in my opinion, there is no point in giving this until and unless it is like progressing beyond 25 or 26 millimeter of axial length. That's another question. What do you do biometry in the OPD or under anesthesia, and how many times you do it? Yeah. If child is cooperative, if it is 4 or 5 years and with no neurodevelopmental issue, a normal child, we can do non-contact biometry with IOL master or Lenstar. And for if child is not cooperative, definitely you can do examination under anesthesia in OR, and then you can do biometry. What is your there's another question. What is your follow-up guideline for premature infant? Do you review all infants with or without ROP at 4 to 6 months? Yeah, for all ROP babies, irrespective of whether they are treated or not treated, we give them a follow-up period, and we counsel parents that they need a 6-monthly checkup, and at least up to 5 years of age, just like treated ROP, we advise them to have a routine follow-up. It's another question. Do you consider that 0.02% atropine is more suitable as pharmacological treatment? So as I stated earlier, we are not having any dosage related atropine treatment we are not having any published study, we are not having any literature on the dosage of atropine which is effective in ROP babies. So I had a very interesting question which was sent to me in email, and that was about how to create the awareness for ROP screening. So it is very important for pediatric ophthalmologist and retina specialist that you have to educate and have a good collaborative relationship with the neonatologist and pediatrician who can send ROP babies to you, and same time you have to educate the staff of those pediatric hospitals. You have to create awareness among parents. You can show videos, and you can have podcast and YouTube presentations for parents. You can display posters and distribute pamphlets in pediatric hospitals, and a collaborative approach between general ophthalmologist, retina specialist will help you to create ROP awareness. And it is very important to give feedback to pediatrician and neonatologist, and even to retina specialist also, that what refractive error or what other ophthalmic changes or other complications you are seeing on follow-up. And you can have various programs on awareness on either International ROP Day or on World Prematurity Day. It's another question. Are the glasses meant to stop the progression of myopia in children? So as I mentioned, these children, whatever optical correction you are giving, it will stop the progression of myopia. And these children behave quite differently from the normal children. From normal children, if you are undercorrecting them, they progresses more faster. But in this ROP baby, there's no process of emetropization, and myopia progression is so variable, and it is not so much after 5 or 6 years of age. So usually they don't progress so much, and if there is progression, better to give them full correction. There's no point of giving undercorrecting the glasses. So another question, what is the difference between myopic ROP patient treated by anti-VEGF versus laser therapy? So laser is a more destructive therapy because we are treating a very large area and we are literally burning the retina with this laser ablative therapy. So we are disrupting the various signaling cascades pathway, and it causes more myopia. While in anti-VEGF we are just injecting this agent and it stays for just 20 days. So it doesn't disrupt the signaling pathway, and therefore the difference in myopia arises. Yeah, so thank you again for joining us me today, and thank you CyberSight for providing me this opportunity to present. Thank you very much. Have a great day.